The topic today is going to focus around inflammatory arthritis, and we're looking at how patient online access can help patients manage their own inflammatory arthritis, how it can help them understand their condition, and in the end, we're looking at what you might call a patient-centered or person-centered system of care. I'm Ralph Sullivan. I'm the Royal College champion for Patient Online, and I have with me Imran Khan, a clinical support fellow who's helped me and in fact driven most of this guidance we're going to talk about today. I'd like to start with this quote, and I'll just give you a minute to read it. And for me, that captures the whole ethos of the reasons for giving patients access to their records online. I've been doing it in my practice since 2006 and found it really, really helpful for some patients. And we're going to talk today about how you can achieve the same thing. This is what we hope you'll learn from the webinar. Clearly, there are safeguarding, there are information governance issues about patient online. Some patients struggle with accessibility to the information, and that's not just a matter of visual impairment, health literacy, ability to use the information, understand the information, and integrate it into their thinking about their illness are key factors. And of course, there are many patients who are not familiar with the level of internet experience you need to be able to use Patient Online. But more about that later. We're going to be talking about the use of coded records relating to inflammatory arthritis and managing test results, blood monitoring of DMARDs, for example, in arthritis, and where the whole concept of record access fits into a care and support planning for the patient. As the little image on the right says, it's about changing the conversation in the consultation to what matters to you. And this is how we're going to go about it. First of all, a quick introduction to Patient Online for those of you who may not have familiarity with some of the details of how Patient Online should work. And then we're going to talk about the benefits of using Patient Online, particularly using it to access test results in this context. There are other ways in which Patient Online record access can help with preparing for consultations from the patient point of view. And then we'll pull it all together at the end with a clinical scenario that we hope will be very helpful. And please do record questions as you go along. On the left-hand side of the screen, you can see an option to type a question into the box and then click send. We'll receive them and address any questions you have at the end of the presentation. I hope you have a good connection. We have had one or two people in previous webinars who've not been able to hear clearly what is being said. This tends to be due to problems at your end. We have found our system is pretty soundproof up to now, but do let us know if you're having difficulties. And I'll hand over now to Imran to tell you more about the our program that we run at the college.
Thanks, Ralph. So I'm just going to talk a little bit about what the Patient Online program here at the RCGP is concerned with. So it's basically a program that's funded by NHS England, looking at providing some resource and guidance for practices and some for patients to enable them to use Patient Online services. Currently, the toolkit is being updated and will be sort of online in full in around September, October time. The aim is to basically increase the awareness and confidence of patients using Patient Online, and the toolkit itself is a set of instruments and guidance templates that allow practices to engage safely with a patient online, help them manage that transition to using it for various different aspects of care. The toolkit that we are focused, there are a number of different areas we're focusing currently. These include end-of-life care, dementia, diabetes. So there are other areas as well as arthritis that we're going to look at today. This is in addition to some events and presentations that we're going to be doing in October, the details of which will be on the website shortly. Throughout the programme, we've had lots of involvement from other Royal Colleges, the Royal College of Nursing, other academic and voluntary care organisations like Macmillan for various aspects of different guidance and make sure it's in line with current guidance. I'm just going to briefly walk you through what patient online means generally. So traditionally we think of patient online as being able to book and cancel appointments, order repeat prescriptions. Lots of the work we've been doing recently has been looking more carefully at using the detailed coded record. So that's specific parts of the information on the patient's records itself. In the toolkit, we focus on specific areas, including information governance, safeguarding, how to overcome some of the barriers that would prevent practices from enabling the coded access. And they're the sort of areas that we're focusing on and will be released as part of the toolkit. So this includes guidance on safeguarding, aspects like coercion and data quality in terms of the actual record itself, and managing that transition to releasing that record on patient online. And the toolkit itself has lots of other useful information, such as templates that can allow that safe transition to giving that patient or enabling that patient to have access to patient online, their detailed coded record, and if considered part of the extended care record as well. Now, the extended care record is not currently a contractual requirement, and Ralph is going to go through that with you now.
Thanks very much, Imran. Yes, to put things into context, as Imran said, in the screen here you can see appointments, medication and detailed care record highlighted. And within England, GPs have a contractual requirement to offer patients access to these things online. The extended full record access is possible, all our systems will do it, but there's no contractual requirement to do so at this time. And what are we doing? Well, these are some figures that are available to us all on the NHS digital website. There's something called the GP Data Hub, which is very easy to find, and which has things like numbers of doctors in England, numbers of staff in practices, quality outcomes framework data, but it also has this patient online management information, and you can find several pages of data. This is the national level of data of uptake as a percentage of the population in England. And you can see that appointments and prescriptions in February were around about 23% of the population were registered for those services. Record access much lower, started later, clearly is a bigger ask for practices to take this on board. And in March, 4.3% of patients in England had access to their detailed coded record. This is going up. As you can see, in May it had gone up to 5.9%, which is a significant rise. And the number of transactions in that month of May were 646,000 times that patients accessed their detailed coded record. So it is happening, it is increasing. We looked at attitudes a couple of years ago. This is an online survey that the college carried out. Most of the respondents were GPs, practice managers. 75% of the respondents to the survey were offering detailed coded record already at that point. So these were people with experience of record access. And this is what they said about reasons why they could see for recommending record access to patients. Right at the top, access to see what the test results are and see what is in their record. Patients are perceived to be interested in what is in there. And in my own personal experience, many patients will look at the record when they first get access, and they may not look at it again unless they have a particular reason to do so. But their key thing is that they want to know what is in their record, and are very satisfied at being able to do so and see what the practice has recorded about them, to see if it's accurate, see if they've missed anything that should be there. We get very positive feedback from patients once they've been able to look at the record and see, actually, yes, that is a good representation of their health. Managing long-term conditions, helping patients manage long-term conditions and look at data, particularly about those long-term conditions, is a core use of patient online. Clearly, people with long-term conditions make up 50% plus of GP consultations. It's a lot of our work. Those patients are the ones who have a lot of contact with the practice, and patient online is most useful for them. There are problems, there are difficulties. There's a lot of technical jargon, a lot of difficult information for patients to assimilate within patient records. The concept of health literacy is quite interesting. The numbers suggest that actually an awful lot of people would struggle to understand what is in their health record. And this is where practices can really help a lot for patients to get the benefit from record access. A few figures on the screen there make the point. The person-centered toolkit provided by college has some really good links to excellent resources about health literacy and how practices can help improve or deal with poor health literacy. And we all know about the digital exclusion problem, that the patients who are most likely to have long-term conditions and most likely to benefit from record access are also the same group that are going to be least competent and least confident about using the internet. But where a patient does want to use patient online but doesn't feel they have the skills, there are organisations out there to help. And the Good Things Foundation has done an awful lot of work over the last few years. There's some links here about projects. The first one with NHS England, the second one with the Department of Education, are all about finding ways to make it possible for people to learn to use the internet and to use it safely and securely. There are lots of online training centres around the country, and the link there takes you to a page where you can search for local training courses, training organisations within your own locality to see where you can refer patients to if they want to use patient online but feel they don't have the internet skills to do so. So, summary so far of what we've talked about. We've tried to give you an idea of what the patient online programme is. We've tried to give you some idea of how patient online is being used in the country already, reasons for recommending it to patients as perceived by practices with experience of the detailed coded record, and a little bit about some of the problems patients have who can't use patient online but would like to. I'll hand you back to Imran now.
So we're going to look at how patients can use patient online for inflammatory arthritis. We know that inflammatory arthritis is over 400,000 people in the UK that suffer with rheumatoid arthritis, approximately 100,000 with psoriatic arthritis. So it is a significant condition, and often these patients have got complex medical histories. They've got complex medical regimes. So they would benefit from booking and be able to cancel appointments just like any other patient ordering repeat medications. Often they will have a higher burden in terms of having to order repeat medications. They will often be on lots of different medications, and they'll often have very specific medications that often are normally managed by secondary care or through shared care agreements through the practice. But we're going to look more closely at the detailed care record and how they make you be able to use that. And if you look on the right hand side there, that's basically the areas of the detailed care record where they may benefit. They will be able to access the problem list. They'll be able to understand other aspects of the care that are coded, their BMI, their work status, their examination results. Often the letters or annual reviews have coded information, such as the DAS-28 that come back from the hospital records, and often is coded by the coding staff at the practice. Test results, obviously, the patients with rheumatoid or psoriatic arthritis have multiple tests, or on any DMARD regime generally will have lots of tests. And often they want access to the test results, whether that's by ringing their practice or through their secondary care contacts. But Patient Online gives them these test results. It will have the arthritis relevant codes. Like I said, often practices will code as part of the annual review their current disease activity or how they've been managing. And often the care plan codes themselves are in the detailed coded record. An idea of the past medications they've been on is useful, especially if they're going to be if there is any confusion about what the current regime is, and obviously allergies and are an important part for the patient to be able to understand, in addition to all the preventative aspects that allow them to engage in management of their own condition. We're going to go into a little bit more detail into how they may use all of that information shortly. Extended record access, so that's the access to all the consultation notes, all the documents, for instance, in systems like DocMan, and access to the free text of the consultations themselves. That's not currently mandated by the GP contract, but also has some benefits to patients with inflammatory arthritis, as they'll be able to access all the records and the letters that come back from the hospitals. Obviously, often they'll have copies of these themselves, but this would give them an easy place to sort of reference all their care plans or historical care plans and their current care plans. It'll also detail discharge reports, any radiology reports, and other referral letters that may not be specifically related to their rheumatoid or inflammatory arthritis management itself. So in terms of actually using the detailed coded record, and that's what we're going to focus on more than anything else, it's about, first and foremost, it's about the patient engaging with their own record, and that can be identifying any inaccuracies that may be present. It's a way of the patient looking at their own record and saying, actually, that's not quite correct. That's not what my idea or my perception was. And it may not be that they sort of, it's not a confrontation that's involved. It's just about correcting something that they've seen that's not technically correct. But it's more of a safety net to ensure that the record's up to date and reflects their views or their preferences. And it's about generally improving health literacy through access to the detailed coded record, by them looking at their problem list, looking at some of the goals that they've set in the past, looking through their test results. They become more engaged, more interested. It's a bit like walking the number of steps you have in an application. It's not that it's providing you specific information. It's about you becoming more engaged with that information. And by giving them access to it, they become more inquisitive, and in doing so, become more empowered to ask questions and to become more involved with their care. And that's basically our key driving message for the entire access to detailed program. It's about getting patients to become engaged and empowered, and then the care itself to become more focused around what the patient wants, not about what the clinician or what they feel is most relevant to the patient. It's about what the patient thinks is most relevant to them. It's often the most important aspect of care, and that's all about what Ralph was talking about earlier, about person-centered care. Access to blood test results is something that obviously is important in rheumatoid or psoriatic arthritis or any inflammatory arthritis, because often it's something that's done regularly to look at whether a condition is stable, and whether something is their care is improving, or there's anything that specifically we need to address, or the patient needs to address. Often there's a concern that if you give patients access to blood test results, they will know what to do with it, or that they will cause some concern from the patient's perspective. But in things like inflammatory arthritis, often there are very specific sets of guidelines that either are provided through shared care agreements with rheumatology departments and rheumatology teams, or there are specific markers that the British Society of Rheumatology and NICE have agreed are sort of set in stone, if you like. That they are definitely something that the patient should be aware of, and they can look at themselves. And by giving patients access to these results, they can have a look through. They can, and it encourages them again to understand what a good white cell count is for them, what a good CRP is for them. So this slide here shows the current British Society of Rheumatology guidelines for what to look out for, and if your particular rheumatology or shared care agreement doesn't include a very specific set like this, and I think it is safe to use this sort of set that's advised by the British Society of Rheumatology and NICE as sort of a criteria or a safety net to allow patients to look to see if any of their results correlate with any of those. And again, it's another way of getting the patients to become more engaged in a positive way. And not only that, it provides a safety net for the practices and the teams. I'm not saying that the ultimate responsibility for the test result remains with both the rheumatology team and, if it's a shared care agreement, with the GP looking at those blood tests, because like Ralph was saying, there will be digitally excluded patients that won't be able to do this. So that responsibility rests with the clinician, but it's just another opportunity for the patient to get involved with their own care.
And it can be very reassuring, can't it? If patients continually see that their test results are within an acceptable range and they know exactly what the range is, then it gives them comfort and stops them worrying unnecessarily. Yes,
it's just another aspect. And the other thing they can look at is blood tests and blood trends over time. So they can look at how their liver function is behaving over time, how their renal function is behaving over time. And one area that actually Patient Online has benefits, even over and above what the rheumatology departments will have, it's got a longitudinal view of all those test results throughout the patient's history. Not just because often patients move, they move areas, they may move rheumatology departments. So often the only place where this historical information with regards to blood tests is kept is with the GP and the GP record itself. So often it does have that benefit, and like we'll talk about later, all these historical blood tests and these trends, the patient is able to use that information. They can look at it. They can even take it to their rheumatology appointments if they wanted to, and they can take all the historical information with them. That is further guidance on how patients can look at their own how they can share their record in the toolkit. So we're not really going to go over that here today. But being able to view trends, particularly in things like rheumatoid arthritis, can be useful for the patient. And again, it gets them more engaged. And being able to actually, lots of the guidelines, including the guidelines from the recent NICE guidelines, suggesting actually it may be these gradual increase or gradual trends in blood tests that may be an early sign and a way of picking up certain early signs of deterioration. And again, it's something that the clinicians should pick up and can pick up, but it is something that the patients themselves can look at too. This is I put this slide up just to show a piece of work that was done by the City of London University and UCLH that looked at a group of 100 patients with rheumatoid and psoriatic arthritis, and they were looking at, it was a very specific study looking at allowing patients to have access to their own blood test results in the context of being on methotrexate, and instead of it being the clinician who would call the patient in, it would be all self-directed from the patient's perspective. So the patient they'd be given access to their own results, and then they would, if they felt things were deteriorating or there was something particularly of concern, that they would contact the rheumatology team directly. So the interesting thing about this study was that actually outcomes weren't worse. They were the same as if the rheumatology team were contacting the patient with regards to blood tests. And actually the number of contacts with both the secondary care team and the primary care team decreased without any consequential decrease in pure outcome in terms of number of flares, their scores, their reviews, etc. So that was the interesting thing about that, and that's another reason that we promote it. It's about allowing the patient to make some decisions for themselves. Obviously, the primary care team and the secondary care team are there for them if they need them, but and not many secondary care teams or primary care teams operate like this study, although some are starting to do that more frequently now. It's about getting them to become more engaged with their test results. And lastly, we're going to look at how patients can prepare for consultations. And Ralph is going to talk a little bit about that preparation before we go into an example. So far we've looked at Patient Online gives patients access to the recorded, detailed coded record and some of the more specific aspects of the detailed coded record relevant in inflammatory arthritis, and how this idea of the patient accessing that coded information enables them to become more empowered, more engaged, and therefore sort of better person-centered care to be delivered. And Ralph is going to go through.
Thank you very much, Imran. Yeah, we talk quite a bit about person-centered care. I find this little diagram here is quite helpful in putting it into a structure. And you can see a URL for the paper behind this plan. So within any clinical patient context, Patient Online fits in this space where a patient is preparing for a consultation, for a conversation with a healthcare professional. Patients need information. They want to know as much as they can before they go in. The patient has an agenda when they come in to see a doctor or a nurse. That agenda is most functional if it's well informed by the patient's health state. In other words, what's in the record that they can use to find out what matters to them, what they want to get answers to, what they want. It's not just a question of them thinking about their symptoms, but they can think of more subtle things. And this is where Patient Online really fits. When patients have looked at their records, looked at maybe the recent hospital reports, looked at maybe blood test results, looked at information about comorbidities. They can come into the appointment thinking, I've got these 2 or 3 things I want to say. These are things that matter to me now. This is what I want to move on. For the health professional, you're seeing a patient who knows a lot of the background information. You don't have to tell them about blood test results. They probably know what they were, and they know whether everything was fine, reassured, don't need to talk about it, or whether there was an issue that needed to be addressed. Makes the conversation much more functional. It addresses things that patients are concerned about, the patient's engaged, is more able to understand information from the health professional, is more likely to engage, and that has beneficial outcomes in terms of self-care, of following up on advice, adherence to treatment regimes. And the second stage is about recording. When you've had that consultation, the data you record can be recorded with the patient in mind. So the problem list information I've just highlighted on the right-hand side of the screen, that can be coded in a way that the patient can understand and can expect and can use to help themselves make things happen, to implement actions that meet their needs. And that information is there for them at review to see, this is where we were last time. Have my care plan goals been met or not? So there's a lot more information about how to implement person-centered care in general, and the paper shown on this screen is linked through the person-centered care toolkit. The collaborative care and support planning guidance is also really helpful in this respect, both excellent resources in how to provide person-centered care, and Patient Online is working closely with the person-centered team at college on this area of our work. To reiterate, this is an iterative, cyclic process of informed patient, informed consultation, better planning, improved self-care, moving around to preparation for the next review, and so on. And Imran is now going to talk to you about Andrew Dearden, a patient with rheumatoid arthritis.
Okay. So I'm just going to go through a short sort of set of clinical scenarios that may sort of exemplify some of the ways you could use Patient Online in a patient with, we're going to use this patient with rheumatoid arthritis here. So Andrew Dearden is a 61-year-old with rheumatoid arthritis who is on methotrexate. He's also got hypertension and chronic kidney disease, 2 chronic conditions, and he thinks that having Patient Online access to his blood results might help him to sort of monitor his condition more fully. So, in a sense, the data coded record available to Andrew will allow him to look at his blood test results, the codes, the attached values. They will, most of the systems employed by general practice today have a set of units and reference ranges attached to those results, so you'll be able to see briefly what the context of those results are and the reference ranges. In terms of his methotrexate, and it'll be important for Andrew to look at other aspects of the coded information, the white cell count, the neutrophils, platelet counts, etc., MCV, AST or ALT, depending on what the local lab uses, creatinine, EGFR. Obviously, he will want to look at other aspects of his inflammatory markers, particularly such as his CRP, ESR, and his full blood count. And because he'll have an understanding already of what they mean from his contact with secondary care and having rheumatoid arthritis in the past. So resources that he may be able to use to access to understand some of these test results can be found in the National Association of Rheumatoid Arthritis, which has a really clear explanation of some of the tests that are commonly carried out for patients with rheumatoid arthritis and indeed psoriatic arthritis, and they give a breakdown of how they can look at their CRP, ESR, their full blood count, how they can use that information to identify flares, etc., and how they can use it in a sort of long-term way to assess whether their condition is currently stable or not stable. Obviously, there's lots of clinical input that goes with this, but it allows the patient to become more engaged with their own blood test results, more empowered by their own blood test results. Other resources that we recommend are lab tests online. Again, patients can have a look at very specific markers such as ALT, ALP, ESR, CRP, any of the common lab tests, and indeed some of the more obscure lab tests, to have a sort of more full explanation of what that actual test means, how they should interpret it, and we've talked a little bit about what very concerning features of those tests are in a previous slide, but often if patients want an explanation of the test itself, there's various resources, and we'll put more resources in the actual toolkit when it's online. So if we follow this scenario a little bit further, he has some follow-up blood tests. He logs onto his practice patient online portal to view his results. He sees that all his blood tests are within normal limits apart from his CRP, which is 16. Now, he's recently been in contact with his secondary care team because he's recently had a flare, and he was asked to get some follow-up blood tests because his CRP was much higher previously, but it's now 16. His GP reads his latest CRP results and writes that his CRP is satisfactory and no action is needed with regards to CRP because it's improving. Now, I put that in because often on patient online, if that part of the DDL-CoRE record is enabled, then the GP can write a specific comment that relates to that specific result. So whilst the CRP of 16 may not normally be acceptable, in this case, the GP would have looked through his past results, seen that it's actually improving, and that it's a satisfactory result in terms of his flare, and no further action is needed from the patient as the CRP is improving, and there's no further concerns. And that part is something that GPs can use to sort of attach information to the test results. It's a way of providing information, a dialogue between the patient and the GP, and again, it avoids the patient having to ring up the surgery, ask what he needs to do with this result. It's sort of a one-stop shop, if you like. But equally, that CRP of 16 may be of concern, depending on this patient's background. And it still may be and similarly, if the GP wanted to write, actually, this is not satisfactory, please make contact with us, or please make contact with the practice to book a follow-up appointment, etc. Or please book another set of test results in a week's time. I've left you a form at the front desk. That sort of information can be attached to this. It doesn't mean that you can rely on this. However, the ultimate responsibility remains with the GP for managing that result. So if that CRP of 16 is a particular concern, it's still the onus of the practicing clinician to get in touch or make an attempt to get in touch with the patient to make them aware of the plan. It's still the GP's responsibility to manage that result. Using patient online is just another method of managing it. If we take the scenario a little bit further, we can see that Andrew's had a stable period, and and he's due for his annual review. He has a repeat set of blood tests taken before his review in agreement with his GP, which include his all his normal blood tests, full blood count, renal function, liver function, etc., and also includes his cholesterol and perhaps his HbA1c. And he notices that his rheumatoid, he may notice that his cholesterol is raised, for instance, as he's been able to access his detailed coded record. But otherwise things are stable, and it gives him an opportunity to look through his record before his appointment for his GP to see what may be important to him. Ralph talked about this iterative loop, and I'll talk a little bit about it now in terms of how that patient may manage it. So if we take a particular point, so if we take the red section, for instance, a GP may have an initial consultation with a patient, review the patient and do a general assessment, perhaps. This could be part of an annual review, it could be an interim review. They could look at their underlying cardiovascular risk, etc., all the things that are mandated in both QOF and recommended in NICE by NICE. He could update the plan, the Q risk, etc., whatever the plan may have been. In this case, if we assume that, so let's pick a section. So if we imagine the patient before their review, they've got their blood results, so they will typically start at the bottom there on the green section. They will look at their coded record via patient online. They'll see their previous cholesterol levels, their previous Q risks, etc. They'll see all their previous blood results. He'll move on to the next step. He'll look through all this information. He realizes that his inflammatory markers are all stable now, so that's not an area of focus for him. He notices his cholesterol has been steadily rising over that period, although his BMI and his weight has remained stable. So he's a little bit concerned by this, and this is something he needs to reflect on. And so this is something that he wants to bring up at his annual review. So he wants to see if he needs to consider treatment for this. So this is something that he can bring to the annual review process, discuss it with his GP. So this is now the focus of the consultation, his cholesterol. He sort of understands that his rheumatoid is controlled, so the GP can sort of focus on the other areas, and it's a more focused review, and he can go through his other aspects that may be particularly important to him now. Seeing his raised cholesterol, he can do a cardiovascular risk assessment, Q risk, etc. That's normally indicated in this sort of scenario. In this scenario, for instance, the GP may say his Q risk is elevated and a statin should be introduced. They can discuss that, and they can introduce a statin, and again, the cycle would then continue with the patient looking through their coded records, seeing if their cholesterol comes down, seeing if anything changes with regards to liver function, etc. And again, it's an opportunity to get engaged with the entire process. Again, I'm all thought we've talked about the fact that there's not just primary care that's involved with the managing patient results, and indeed, we've tried to follow the recent NICE guidelines that came out in July around management of rheumatoid arthritis, and we haven't talked about management using patient online to manage flares or in the diagnostic part, because that's still something that's firmly rests in the specialist arena. And in terms of management of flares, again, whilst we encourage patients to look at their test results, and if they think actually their symptoms correlate with and their test results correlate with a flare for them, we can recommend that they use it for that sort of respect. But again, the recommendation is still that they contact their secondary care team or their specialist care team with regards to flares, and that's in line with NICE guidelines. what NICE do recommend is all patients have annual review, and often patients who are very stable will have been discharged from secondary care, although they will still be on regular medications. And that annual review, which includes assessment of disease activity, a measure of how they're getting on now, and that could be the HAC score, which is something that's recommended by NICE, or their DAS-28. All these things can be done by the patient. The checking for development of co-morbidities, other conditions that may be affecting their care. We talked a little bit about the patient developing dyslipidemias and developing other problems, not necessarily because of their rheumatoid, but in general they're more likely to have other medical problems. It gives you an opportunity for the patient to look at their record and become more engaged with the annual review process itself. And so the annual review that I've got on the slide there is the current annual review for patients with rheumatoid arthritis that was advised by the recent NICE guidelines, and is also what's mandated generally in QOF. It's not quite in line with QOF now with recent recommendations, but it's very, very close. There's still the need to engage patients in assessment of their functional ability, and again, it's about empowering patients to be able to do certain things for themselves and be more engaged in this process. And that's what generally we were encouraging patients to do, and what having access to the DDR-coded record encourages them to do.
Thank you very much, Imran. We're just about coming to the end of what we have to say about arthritis and patient online now. I hope it's been interesting. I hope we've met the issues that you hoped we'd raise. We have a few questions to go through, and we'll do that now. So I'll just bring them over on a laptop to my left so we can both see them. And let's see. First, we have a question. I think you know who's asked them, so I'll just go through the question. First one is about whether patients are signposted to relevant patient organisations who can help as part of Patient Online. No. The way that Patient Online works is that patients will see on their smartphone or on a web page on a computer a form breakdown of their GP record, which will be either just the codes represented in whichever form that the GP system allows, or the attached files, letters, scanned results. There may be links within the app that the patients use that move the patient on easily to relevant information, which may or may not include a list of self-help organisations, charities, patient organisations so they can seek further advice from. That particular facility is something that is decided upon by the companies that provide the Patient Online software, the intermediary software between the GP system and the patient. It's not specifically part of the patient data that's transmitted through the system. Couple of questions then about acute phase reactants, ESR and CRP, and whether we didn't put them in an early slide, but we talked about them later, didn't we?
Yeah.
I mean,
we've talked about access to all blood test results, and obviously they would all be included. And if you've got access to any blood results, you'll have access to this ESR, CRP, all of the results that are carried, all the tests that are carried out.
Yeah, I think to be specific, there's a question which came up later, which was about whether monitoring blood tests that weren't done in the practice would show up in the Patient Online record that the patient could see. The defining issue is that if a recode for a blood test result is present within the GP system, the patient will be able to see that. If it's not in the GP system and not filed in the GP system, the patient won't be able to see it. So a blood test result that is a test that's done in hospital, where the result may be available to the practice, but only by viewing it, but it's not actually filed in the patient record, will not be visible to the patient. So we're really talking about patients having access to work done by the practice, but not directly by this route to work done in hospitals, unless there is a system within a particular locality for hospital results to be transmitted to and filed in the GP record. The next one, some investment in patient education is required to ensure that patients can really get the best out of patient online records. Are there plans by RCGP to include this in some way? Yes, the answer to that is yes, to both elements. Health literacy, patients being able to understand their records is absolutely central to them having access to their record. Now, this is a complicated subject, and it involves both written and verbal information for patients to help them understand what the records mean. Clearly, if the patients misunderstand the record, that can be harmful, not helpful, can lead to all sorts of assumptions being ill-founded. It is certainly the case that the practice has a responsibility to ensure the patients are not harmed by having access to the records, and out of that comes a responsibility to discuss and inform patients on, particularly on data that could be worrying and upsetting. We have written in the guidance about this. One could talk about it quite a long time. But yes, you're right, there is a basic requirement. And obviously the health literacy is quite a complex subject. The links that I put into a slide early on go to some really valuable work and guidance and tools that practices can use or point patients towards to improve their health literacy. A key thing about patient online is that the information that patients have lists the concepts that affect them. It lists their illnesses, comorbidities, major procedures, risk factors. They know what to look up. They won't spend time learning about things that aren't relevant. So it focuses their own efforts to improve their health literacy quite effectively. Sorry, I've lost the list of questions on the laptop beside me. Spent too long talking. That's not usually a problem I have. Success, got it back. Right. Would 20-minute appointments for GPs have with patients with rheumatoid arthritis be a good opportunity to introduce patient online and provide some encouragement to use? Absolutely, definitely. I think this is the single most useful thing that practices can do. Whatever the long-term condition, patients will find patient online helpful, and face-to-face consultations and a recommendation is a really good way to spread the word. So yes, I would encourage you to think about that as an option without doubt. Next question is, there is an inflammatory arthritis toolkit hosted by college which highlights all red flags and links worth mentioning at the end. Thank you. We've mentioned it. Very timely and helpful question. We will be writing guidance. In fact, it's very near completion, isn't it? And that will give us an opportunity to talk a lot more about other resources that practices can use. We had to be a little bit selective with the webinar, but that is clearly something very important to us, and we will be mentioning that in the guidance. A couple of statements about, and due apologies, we seem to have misrepresented the names of the National Rheumatoid Arthritis Society, and we will make sure we get that right, and we will edit the webinar slides before we go any further. Is there a simple patient leaflet explaining patient online? Yes, there is. The NHS England have produced a whole series of very useful leaflets aimed for patients. Practices can order those through the NHS England Patient Online website. The Royal College Toolkit includes some general templates for patient information leaflets and some advice about the sort of things that patients need to know if practices are thinking about putting together a set of information on patient online. So yeah, first of all, NHS England, think about ordering leaflets there, and the toolkit from the college has other leaflets and advice on things that fill some of the gaps and go into a bit more detail than the NHS England materials do. And the last question, although patients remain under secondary care for management of their RA, GPs can play a major part in helping to manage co-morbidity, especially cardiovascular disease risk. Very amazing. Yeah. Do you want to add to that?
Well,
no, you mentioned
that was more
passing.
Yeah, that was. I think we know that GPs are good at managing the overall view of a patient, including there, and there are lots of studies showing how good patients are good at managing those comorbidities and looking at those risks into whether it was in terms of the cardiovascular risk or risk of osteoporosis. We are good at that aspect of care, and like I said, the more specific management of rheumatoid arthritis would remain with the secondary care team. But in terms of their overall health, GPs are good at managing that, and that's part of the annual care review. And a bit about what I was talking about, the new NICE guidelines. That's where we sit.
Where specialist journalists do well. Thank you very much. That's all the questions we have. We've more or less come to the end of our time. So I'd like to thank Imran Khan for joining me in doing this webinar. I hope you found it helpful and useful. It will in due course be published by college on the Royal College YouTube feed, and will be part of the new Patient Online Toolkit that will be launched in October, along with updated and extended guidance on clinical benefit of Patient Online. Thank you very much, and goodbye from us.